Good morning to my supervisor, Puan Cik Wan Nasiah Sakinah binti Cik Wan Ahmad, supervisor at MSU at Hospital Sultan Abdullah UiTM. Okay, my name is Muhammad Shamiruddin. I am a student of Bachelor of Medical and Health Sciences with Honours Program at OUM. Today, I am pleased to present my case study titled The Patient Assessment and Management of a Patient with Psychiatric Problems, a case study on major depressive disorder with psychotic features at Hospital of Sultan Abdullah UiTM. This case study is based on my 80 hours clinical placement at the mental health unit, which I completed in February 2026 under the supervision of you, Puan Sakinah. Right? So without further ado, I will start my presentation now. Okay, let me begin by providing some context for my placement. The mental health unit at Hospital Sultan Abdullah served as an invaluable learning environment over 10 weekdays. I completed 80 hours of clinical posting, which allowed me to bridge theoretical knowledge from my textbook with the real-world practice of mental health. This experience gave me first-hand exposure to the multidisciplinary team approach, which research by Santos and colleagues in 2022 confirmed improved outcome in psychiatric settings. Okay, introduction to clinical placement. Okay, so this is the detail of my clinical placements. So institution is HASA UiTM, unit is MSU inpatient wards, durations in February 2026, 10 days weekdays randomly. Okay, and then for hours is 8 hours per day, so total hour is 80 hours. Objective is number 1 is present comprehensive assessment of MDD with psychotic features. 2. Describe chronological management using patient care process. 3. Demonstrate application of theory in clinical practice. 4. Reflect on MDD role in psychiatric care. 5th is highlight key learning for future practice. Okay, this is the patient demographic data. Okay, that I take during my clinical posting. So to protect his identity and maintain confidentiality in accordance with ethical guidelines, I will refer to the patient as Encik Azman. Okay, Encik Azman, okay, this is a pseudonym name, not real name. Encik Azman is a 45 years old Malay, a Malaysian citizen residing in a suburban area of Kuala Selangor. He is married and has 3 children, aged 12, 15 and 18. A position, he works as a mid-level manager at a private logistics company. A position he has held for 15 years. He holds a diploma in business studies and his religion is Islam, which play a significant role in the worldview and coping mechanism, as we all know. Alright, so he was admitted to the mental health unit at HASA in early February 2026, 2 days prior to start of clinical postings. General health history. Encik Azman health history reveals several important factors. Okay, regarding to his past psychiatric history, this is his first psychiatric admissions. However, according to his wife, there was a 6-month prodromal phase where he became increasingly withdrawn, irritable, and experienced poor sleep. He had no prior contact with psychiatric services before this. His past medical history includes hypertension, okay, diagnosed 5 years ago, for which he is prescribed for lisinopril 10 milligrams daily. His wife reported that he takes this medication irregularly. Importantly, the bidirectional relationship between chronic conditions like hypertension and depression is well established in the literature. Alright, the family history is significant. His maternal aunt, his auntie, was diagnosed with schizophrenia and received a long-term psychiatric care. His father had a history of alcohol dependence, but no formal psychiatric diagnosis. Okay, this family history represents a significant genetic vulnerability. He is a non-smoker and does not consume alcohol. A major precipitating stressor was being passed over for a promotion of Edward. Kendall and Gardner 2021 emphasized that major life stresses can trigger depressive episodes in vulnerable individuals. Despite the strain, he has a small but supportive extended family network. So next slide. Mental state examination finding. Mental state examination, MSE findings. So I conducted my first MSE on the 3rd day of his admission under the supervision of my clinical instructor. The MSE is cornerstone of a psychiatric assessment, as Norris and colleagues 2022 reminds us. In terms of appearance and behavior, Jazma was disheveled, unshaven with a slump posture. He exhibited psychomotor retardation and made poor eye contact, gazing mostly at the floor. His speech was of low volume, monotonous, and markedly slow. He took long pauses and often gave only one-word replies, demonstrating quality of speech. Regarding mood and affect, his subjective mood was described as down, empty, and he stated there's no point. Objectively, his affect was concentrated and blunted, showing little emotional reactivity. The most concerning aspect was his thought content. He expressed strong feelings of worthlessness and guilt. He voiced nihilistic delusions, believing his insights are rotting away and that he had no future. Crucially, he endorsed passive suicidal ideation, stating, "I don't want to kill myself, but I didn't wake up tomorrow. It will be a relief for everyone. But if I did wake up tomorrow, it will be a relief for everyone." He also revealed auditory hallucinations, a voice murmuring his name, saying he was useless. This distinguishes psychotic depression from non-psychotic NDD. Okay, for cognitively, he was alert and oriented to person and place, but unsure of the exact date. His concentration was poor. His insight was poor. He attributed his experiences to personal failings rather than mental illness. Okay, so for working diagnosis is major depressive disorder identified with psychotic features. Mood congruence. Diagnostic criteria CDSM-5-TR. Number one is repressed mood plus anhedonia. Second, psychotic features congruent with depressive themes. He had nihilistic delusions and auditory hallucinations. Third, significant functional impairment, thought not attributable to substances or medical conditions. Okay, for summary, diagnosis, severe depressive episode with psychomotor retardations, nihilistic delusions, and auditory hallucination occurring after major psychosocial stressor or job rejections. Patient care process overview. The patient care process is a cyclical framework that guides nursing practice. It consists of 5 interconnected phases. It begins with assessments, where we conducted the MSE, took a detailed history and gathered collateral information from his wife. This leads to diagnosis, which is the second one, where we use clinical reasoning to identify problems and formulate the diagnosis. And then we go to the next is planning, which involves setting short-term goals like safety and stabilizations and long-term goals focused on recovery and functions. Then comes implementations, okay, where we deliver pharmacological, psychological, and social interventions. And then the last one and not least is evolution involved ongoing monitoring and modifications of the plan, which then cycle back to assessments. This is not a linear checklist, but a continuous dynamic process. Okay, slide 8. Phase 1. Phase 1 is immediate stabilizations. Okay, this is for days 1 until 3. Phase 1 occurred just before my posting began, but its effects were evident upon my arrival. The priority was safety. Encik Azman was placed in a room near the nurse's station with 15 minutes close observations due to his suicidal ideations. A low stimulus environment was maintained to reduce agitations. Okay, the NH used a non-confrontational, supportive approach to build trust and provide assistance with basic care like meals and hygiene. Pharmacologically, the psychiatrist initiated combination therapy, which is a first line of for MBD with psychotic features. Okay, he was started on sertralins and SSRI antidepressant at 50 milligrams daily to target core depressive symptoms. Cipriani and colleagues 2022 note that sertraline has a favorable side effects profiles. Okay, Encik Azman also started an olanzapine. Okay, a typical antipsychotic at 5 mg ON at night to target psychotic symptoms and aid sleep. Okay, olanzapine is one of the most studied antipsychotic for combination therapy in psychotic depressions. Okay, the NA staff monitored him closely for side effects such as sedation or akathisia and ensured medication compliance. Alright. Okay, this is the phase 2 engagements. Okay, days 3 until 6. Okay, and my roles lah. Okay, this phase taught me some of my valuable lessons. On day 3, my role was simply to sit quietly near him for 15 minutes with no demands. He didn't speak, but I learned that therapeutic presence itself is a valid intervention. Okay, alright, on day 4, I brought him a cup of tea. This small, non-demanding act of kindness seems to bridge the gap. He accepted it with a slight nod. I learned that small gestures matters. Alright. Also on day 4, I observed the weekly MDT meeting. Okay, where I witnessed the psychiatrists, psychologists, and occupational therapists and social worker collaborating. This reinforced that collaborative care is essential for outcomes. Okay, the intervention that I observed during this phase included using simple close-ended questions to reduce cognitive load, activities scheduling to encourage time in the day room, and ongoing supportive communications. Okay, by day 7, we entered the therapeutic interventions phase where we saw the first sign of improvement. Pharmacological review day 7. On day 7, because there was minimal improvement in his delusions, the psychiatrist increased olanzapine to 7.5 mg at night while maintaining sertraline at 50 mg. Okay, on day 3, the occupational therapist involved Encik Azman in a simple tabletop task, which is folding laundry. Okay, this activity is a non-threatening, repetitive, and required minimal cognitive demand. Right? I assisted in these sessions. Initially slow and hesitant, he showed fleeting focus. Okay, that occupational therapy in mental health is crucial for rebuilding a sense of competence. Alright, and then come the breakthrough moment. Day 8. Okay, during one of my afternoon visits, he spontaneously said, "The medicine, it makes my head quiet. The voice is not so loud now." This was monumental. I used active listening skill reflecting his statement. It sounded like the quietness in your head is a relief. He looked at me briefly and nodded. I documented this positive change. Alright, okay. Crucially, his passive suicidal ideation resolved at this point. So no ideation of passive suicidals. On day 9, the social worker facilitated a structured family visit with his wife. A staff nurse and I were present. The conversation was guided toward neutral, positive family memories. Okay, family recognition reduces relapse rates. Okay, according to McFarlane 2023 and C. Enrollment 2023. Okay, so the next phase is phase 4. Phase 4 is discharge planning in that 10. Okay, the discharge plan had several key components. Medication would continue with 250 mg and clozapine 7.5 mg with a review to follow up in 2 weeks. Follow-up appointments were scheduled at the Hassa Psychiatric Outpatient Clinic in 2 weeks, and a community mental health nurse will conduct a home visit within the first week. Okay, the family received comprehensive psych medication about the illness, medication adherence, and warning signs of relapse, such as social withdrawal and poor sleep. Adjustment was also placed on a wait list for individual supportive psychotherapy to address underlying feeling of lovelessness. At discharge, his status had improved significantly. He was showered and dressed in his own clothes. His speech was spontaneous. He initiated a goodbye, saying "thank you to me." He denied hallucination, though his insight was still developing. Right. So the adjustment is already discharged. Okay. This is for recovery trajectory and outcomes. Okay, this slide summarizes the adjustment progress for over 10 days, from day 1 until day 10. Psychotic symptoms improved from severe to mild. Depressive symptoms improved from severe to moderate. Social engagement improved from minimal to moderate. Cognitive impairment often accompanies by acute depressive episode, making this improvement significant. Okay, the recovery star holistic progress. Okay, developed by State and colleagues 2021, emphasizes holistic progress across multiple domains. Looking at admission versus discharge, we see improvement in every domain. Okay, mental health symptoms improve from 2 to 6, and for self-care improve from 3 to 6, social network from 1 to 4, and then lastly is hope in recovery, improve from 1 to 4. Okay, this illustrates that recovery involves progress in multiple domains, not just symptom reduction. Okay, so what are the key takeaways from this case? Right. Okay, this is the summary and key learning. Okay, from assessments, okay, the clinic is comprehensive and MSE plus collateral history essential for accurate diagnosis. And then for aspect in diagnosis, okay, we learn how to recognize mode congruent psychotic features in MDD. Okay, for treatments, we learn how to do the combination pharmacotherapy, which is antidepressant and antipsychotic. Sertraline and olanzapine, right, is the first line. And then team approach, ability, collaboration, improve outcomes across multiple domains. And then as for me, from parameters, I learned how to do the therapeutic presence, active listening, and small act of kindness is method. Okay, in the aspect of family involvement, we learn how psychoeducation and support reduce relapse risk. And then for recovery, focus on functional social outcome beyond symptom control. Okay, slide 14 is personal reflections. Okay, this placement taught me lessons no textbook could convey. I learned that therapeutic presence, simply sitting silently with a patient, can be as therapeutic as any conversations. I learned to observe non-verbal cues because posture, eye contact, and affect often convey more than words. I also learned that team collaborations is essential. No single discipline can provide comprehensive care alone. And I also learned that small decision matters. A cup of tea can be a bridge to a therapeutic engagement. Okay, and then for the last and not least is hope in a small improvement. I like to find a hope in a small improvement. A spontaneous thank you for a patient who just days earlier couldn't make eye contact even meant more than any textbook learning. Thank you, Encik Azman, day 10. As Encik Azman said on my final day, thank you, Dek. That simple phrase reminded me that mental health care is more about than managing symptoms. It is about recognizing the person behind the illness. Alright, so this is my references. Okay, and thank you. Okay, now we go to the Q&A sessions. Alright, so Puan, do you have any question to me?
Yes, I have 2 questions from this slide. Can you tell me why were combination pharmacotherapy, Saraline and olanzapine were choose over ECT for this patient?
Okay, this is an excellent question, Madam Puan. Okay, that gets to the heart of clinical decision making in psychotic depression. First, it is important to acknowledge that ECT, electroconvulsive therapy, is actually considered the gold standard treatment for severe MDD with psychotic features, particularly where there is a high suicide risk, catatonia, or refusal to eat or drink. ECT has a rapid onset of action and very high efficacy rates, often cited as 80% to 90% in psychotic depressions. However, in Encik Azman's case, several factors supported the initial trial of combination pharmacotherapy. Alright, so importantly, the team did not rule out ECT entirely. The plan was to review response to medication within 7 to 10 days. If Encik Azman had not shown improvement or had deteriorated, ECT would have been the next logical step. Alright, that's my answer.
Okay, thank you. And for the last question is, what are the warning signs of relapse that family should monitor after discharge?
Okay, there is several warning signs that family should monitor after discharge. Okay, such as difficulty falling asleep, loss of appetite, spending more time alone, irritability, sadness, negative thinking, self-criticism, increased sensitivity. And then in the aspect of functioning, he will have a neglecting hobbies, poor concentration. And then for medication adherence, usually the patient will show symptoms such as resisting to medication, forgetting doses. So if the patient is having all these what we call that as the symptom, so the family should seek for the to hospitals for the medications and treatment. That's all. Thank you, madam. Assalamualaikum.